just to discussion. This is a very controversial question, controversial topic and understudied case. Here a 45-year-old male came to the hospital for calcanean implant removal, which was done outside in January month of this year. So he is a 45-year-old and he had no comorbidities, no significant family history of CAD or non-alcoholic, non-smoker. So whether you want to do any cardiac risk assessment or not is one question. So how routinely will you advise in this age group for cardiac evaluation? This one. And in asymptomatic patient at this age, how will you approach for non-cardiac surgical fitness? So general, if you go by guidelines, there are no, if the patient is asymptomatic, just go with whatever your surgery. So his illness started at the month of January and underwent surgical correction for his fracture. At that time, no documentary evidence of ECG and echo. After 3 months, he had discharged from the surgical site and advised removal of implant, for which surgeon advised cardiologist opinion for fitness. There, echo suggestive of regional wall motion abnormality in LAD territory with LV apical clot. So the cardiologist advised medication for 3 months and given high risk for surgery, and CAG also differed. So after 3 months of wandering, this is the old report. After 3 months of wandering, so patient came to Yelloor Ramesh Hospital for the fitness for surgery, where the echo suggestive of regional wall motion abnormality in LAD territory with ejection fraction of around 35% with LV apical aneurysm, referred to main branch for cardiac evaluation. This is a ECG. There are the subtle ST segment depressions in the inferior leads, and investigation suggestive of whatever the previous finding. So this is the echo, which is suggestive of regional wall motion abnormality in LAD territory with their pseudoaneurysm or healed hematoma, like contained ruptured hematoma picture. And we did the angio, which suggestive of triple vessel disease. LCX is LCX and OM are 90% diseases, and LAD proximal lesion 90% disease, and RCA proximal also critical disease. So here the question is, do you want to go with surgery, or do you want to go with cardiac revascularization or implant removal first? So if you go by the guidelines, especially if at this age group, there is guidelines differ any of investigation, like going with ECG also, because patient is asymptomatic, there is no ECG, no echo. But if you go with our practice here in this case, especially in this case, so patient is already in LV dysfunction. So after multidisciplinary team discussion, in view of the age and triple vessel disease with the LV dysfunction, we removed the first infected prosthesis, and we are planning for elective surgical revascularization of coronary artery disease. So in Indian subcontinents, as coronary artery disease is occurring in younger age population, screening for non-cardiac surgery may be considered when compared to the Western people. For high risk non-cardiac surgery, especially in resource limiting conditions, better to have cardiac evaluation even in younger patients. That's it.